Geyman, a registered dietitian and Israeli nutritionist, host of the Israeli TV show A Healthy Morning on national TV. I'm happy to welcome two world-renowned professors. So I'd like to say hello to Professor Lorent, President of the European Crohn's and Colitis Organization. Hello. And hello to Professor Shomron, Chief of the Gastroenterology Department in Shiba, Tel HaShomer, and also the Chairman of the Israeli Crohn's and Colitis Association. Hello both, and thank you for being here today with us. So, Professor Lorent, we have our first question for today. Are patients that are treated in immunomodulator drugs or biological drugs in greater risk during COVID-19?
So I think it's a very important question because a few months ago when the COVID pandemic started, we were all very scared about this question. We asked our IBD patients to stay at home, not to work, not to come to the hospital, to do nothing. In fact, now we have enough evidence to say that IBD patients are not at increased risk of developing COVID infection. So very reassuring data. And now, except what IBD patients have to do similar to the general population, such as social distanciation and all these things, in fact, they can live a normal life like a non-IBD patient. So good news for our patients. And now my patients are, for instance, back to work.
So that's good news. And actually what you mean is that no one has to stop the treatment, keep on as usual, and there's not a greater risk during this time. Is that correct?
Yeah, so this is a second question. This is a separate question. I would say that overall IBD patients are not at increased risk of being infected with COVID. But also what we know now is that biologics, immunosuppressants do not increase the risk of severe forms of COVID. And maybe, I don't know what is the feeling of Shomron, who know basic science and translational research much better than me, but maybe also this drug could protect by decreasing the inflammatory and cytokine storm against the most severe form of COVID, but we need more data to show that.
So that's actually really interesting. You say that the drugs might actually be a protective effect. So I'd like to ask you, Professor Shomron, what is your opinion? Do you think research has shown us that these drugs actually do have a potential of being actually something that protects our patients?
Yeah, so first of all, I think we concur, Professor פירין-בירולה and myself, that and probably all experts now feel quite secure and reassured about the safety of the biologic drugs during COVID-19 epidemics. And this is for the reason that most of the data coming out, including a registry called Secure IBD, and this is a global registry that collects reports from all over the world from physicians reporting their cases of IBD with COVID-19. So this is a certain look at the situation, but still it has more than 2,000 cases with IBD and COVID-19 infection as of yesterday. And in all of those, so you have no real comparator of patients who are not IBD. But within the IBD, you have some patients who are immunosuppressed and some are not. And you see that patients treated with biologics, and these are hundreds of them, are not at greater risk. The only small exception is that patient on steroids, on corticosteroids, there is a signal perhaps of some increased risk for a more severe infection. And it's still unclear whether it relates to the fact that they get corticosteroids for a very active disease or not. But data from France, Italy, as well as the United States, and also the data from Israel, that we have already a few dozens of patients with IBD and immunomodulators or biologics, does not overall indicate any increased risk, except again for this small signal for corticosteroids, which is the reason perhaps that we are trying to reduce corticosteroids use at any time, but in particular during this time. Regarding very briefly to what Professor Lorent was just alluding to, indeed in some protocols, in many protocols of treatment of patients with severe COVID-19 infection, the protocol will include immunosuppressive drugs, including some biologics, such as a biologic that is anti-cytokine, a molecule called IL-6. And the reason is that there is some grounds to believe that the body reaction, the immune reaction to the virus is a little bit exaggerated in some patients and is a cause of deterioration. So this might be somewhat of a mechanism to understand why perhaps, and I'm saying it very cautiously, perhaps they are not increasing the risks of biologics, but perhaps they might even be helpful in some cases where patients are severely infected.
So
we
this is
still
really
recommend usually to stop the drugs if someone is infected, just to make that clear.
Yes, and then once you realize how to manage the disease, then you might want maybe to add them on. And it's really impressive, I have to say, that COVID is not with us for too long, and already we have so much evidence and can be quite certain about our guidelines. So that's really impressive work, in my opinion.
I have to, again, I would interrupt, and again, I would wonder what Professor Lorraine would say, but I think our knowledge is evolving. And for instance, we started out with the data coming, and we have to recognize that. So we started out thinking that patients receiving both a biologic and immunomodulator are at greater risk. And again, from the secure IBD at least data coming on a daily basis, the plot goes down, and it's now a similar risk, or only tiny higher risk as opposed to other biologics or a monotherapy. So even that axiom that we were thinking about, I think, I don't know, Lorraine, what you think, but it seems the numbers are flattening down there.
Oh, I think it's a key point. The main take-home message for today is that we don't have to stop drugs. It's more important to control IBD, and I think this is a very important message. If you stop, there is a risk of an IBD flare. So it's more important to control IBD. And when the patient is infected, there is one thing you should be aware is that, as always with steroids, you should probably think about stopping steroids. But when you see a patient, at least when a patient is not infected at your clinic, just continue the management as you do. You can control the disease. There is no risk with biologics and immunomodulators. The protective effect against the most severe forms of COVID, I think, still need more data.
Yes. I'd like to take the discussion to another field, which is very interesting to our community here in Israel. That's the whole process of fitting the right biological treatment to the patient. Is there, Professor Lorraine, some example you could give, maybe a case study of the considerations that are taken into making that match between patient and biological treatments?
Yeah, so this is a 1 million euros question. I would say that during 20 years, the last 2 decades, we had only anti-TNF, so we didn't have so much this question. But now we have new drugs, new mechanism of action, new routes of administration. So now we are discussing more and more. What I take into account in my practice, it's first of all the age. I think the age is very important because when it's an elderly patient, you have more risk, for instance, of infection. So in young patients, some drugs have not been approved yet. So the age is very important. Second parameter is the presence or not of extraintestinal manifestation, because up to half of patients will have extraintestinal manifestation, and some drugs have a systemic effect or not. The third point that I take into account is disease complication. And to be honest, nowadays, if you consider stricture, fistula, perianal fistula, after resolution of abscess, still the best level of evidence is with anti-TNF. So I would say the other points are maybe less important because I think we need to focus to have a good treatment of the disease. It's more everything related to the patient, satisfaction, preferences. When you ask, you have IV, sub-Q, oral treatment, some young patients, active patients, they like sub-Q or oral. It's sometimes more difficult, at least in France, with IV. And then there is a cost, but I think cost is a country-specific issue, and maybe it's not the goal to discuss it. But this is usually what I take into account in my practice, even if I would say that today, and maybe it would be interesting to get the feedback from Shomron, the most important is to monitor your patient, and when a drug is failing, to move to another drug. So the sequence is maybe more important than just saying start with this drug or this drug. If you monitor, it doesn't work, you move to another one. I think this is the best management of IBD patients.
Yes, so still the considerations are based on each and every doctor's personal experience and obviously practice. There's not an algorithm or some sort of technology that makes the matching easier. Not yet.
No, because my last word before letting Shomron speaking, I think it's in terms of efficacy, we have to keep in mind that so far we have reached a plateau. So we cannot say that a drug is the most potent and much more effective than another one. If one drug was much more effective than the other one, we would use it as a first line, but it's not the case.
Yes.
So the efficacy is quite close. We are playing around a little bit about safety, but in fact today the risk-benefit does not make a huge difference today.
Mm-hmm. Thank you. Professor Shomron, is there anything you'd like to add into the considerations taken when making a match between biological treatment and a patient?
Again, so I think Professor Lorraine covered it in most points, and the underlying assumption that we use, exactly as was said, is, and it's not an assumption, it's pretty much shown by the literature that overall, when you look overall, the efficacy of those drugs, of the biologic drugs, is overall the same for the patient. There are some nuances perhaps in the safety profile, and I think this is important because, again, once the efficacy is similar, the degree of systemic immune suppression is probably different between some of the newer biologics and the older, mostly the anti-TNF ones that are more systemically active. And this is something that I think Professor Lorraine related to, especially when we speak about elderly population, but sometimes also we relate to it when we speak to younger population as well. If you think that overall efficacy is similar, then safety becomes even more paramount in the consideration. This is something that we discuss openly with patient. On top of that, there is a rapidity of onset of action. Again, there is slight variations, slight nuances in onset of action. And this is sometimes important for patients with a more severe disease, as opposed to perhaps less important for patients who have sort of indolent disease that you need to take control of, but it's not an emergency situation. So all these considerations are basically, as Professor Lorraine mentioned, we are tailoring individual decision to individual patient, mostly based nowadays on the clinical profiling of the drug, and not so much yet, as you started to allude to a genetic proteomic profiling of a patient. There is robust research on this area. I think our main problem is that it's still not replicated enough. So we as doctors want something to be repeated once, twice, or thrice before we can really adopt it into clinical practice.
So that's actually another question that our community had, the whole question around genetics. How much research is being done in the genetic field? How is that helping us understand personalized treatment, tailored medicine? So is that a field, you said that it's heavily researched. Is there a breakthrough that we see coming soon or anytime in the near future?
So genetics is a general term, but the medical community, the IBD community, is exploring many facets of biology that drives IBD, and in that we profile. The community is trying to profile not only genetics but proteomics, which are the proteins that the patient produces, including other features that I will not go into, but eventually to build this biological profile of a patient. And yes, there are efforts in England, in the UK, a big study is now ongoing for really starting, called Profile Study, and people can look it up in the internet. So it's a profile study looking at two different ways of treatment, one by conventional treatment and one by profiling these genetic and proteomic markers. We still don't have the results of that study. Other studies are starting to be ongoing with really taking something from the lab and trying to really treat patient with that, but we will need much more data on that.
Until it can
probably,
become
I think Professor Lorraine also will want to comment on that probably.
Yes, and Professor Lorraine, maybe we could take another angle. Recent research has shown us that there might be specific SNPs to be tied to IBD. So is that also something being researched?
Yeah, there are many, and a lot of money has been invested since more than 1 decade. The story started 20 years ago with not two, and now we have hundreds of SNP that have been identified. But I would say we were a little bit disappointed, to be honest, because still we are not using it in our clinical practice. And I think for me, when I do research, I like when there is at least a small impact on our clinical practice. So we are not using it. Why? Because we are thinking that adding one gene or one SMP after another one, we would increase the accuracy or the capability to detect the risk or to predict the risk of IBD. Unfortunately, every time you ask a new gene or new SMP, you just increase a little bit the probability to predict the risk of IBD. So I would say it's interesting from a research point of view. I think where it will be very interesting, it's connecting the genes with environment, with immunology, with the body, and all these things. But the SNP alone, I think it's insufficient, and it explains only a small part of IBD, and unfortunately, we cannot use it for prognostication in practice.
So not yet, thank you. Another question that I'd actually like to address both of you is, are patients treated with immunomodulators in greater risk of certain types of cancer and in specific skin cancer? And this could be interesting because in Europe we have a completely different weather than here in Israel, so it would be interesting to hear if you have different opinions to this question. So maybe we'll start with you, Professor Lorен.
I will have at the end the same opinion as Shomron, but let's see. It's not an easy topic, but just to tell you, I think what we know now today is that clearly anti-TNF is associated with an increased risk of all skin cancers, melanoma, non-melanoma skin cancers. This is a mild increase, but at least you need a dermatologic surveillance and you need to be careful with sun exposure. So this is for, I would say, anti-TNF. Now we have two other biologics, which are vedolizumab and ustekinumab. As always with these two drugs, we can say today that they are safer than anti-TNF, and there is no increased risk of skin cancer with ustekinumab and vedolizumab. So mild increased risk of skin cancer with anti-TNF. If we look at lymphoma, this is a little bit more complicated. Okay. If you look at ustekinumab and vedolizumab, once again, there is no increased risk of lymphoma in this patient. For anti-TNF, it's more debated. Whether anti-TNF alone is increasing the risk of lymphoma, you have many confounding factors. In one big French study, it was positive. In one very big Danish study, it was negative. So there is maybe a small increased risk with anti-TNF of lymphoma, but it has not been well defined in IBD patients. We have some signal telling us that probably in rheumatoid arthritis, there is an increased risk of lymphoma with anti-TNF, but there is also already a spontaneous increased risk of lymphoma in rheumatoid arthritis, and the patients are different, the age and so on. So I would say overall very reassuring data for all biologics with lymphoma. For skin cancer, the risk is only increased with anti-TNF.
Thank you. Professor Shomron, any specific input to the Israeli weather, maybe specifically now, August, it's very, very sunny. Is there some precautions that patients have to take that are greater than the general population, in your opinion?
Yes, so definitely patients who are taking immunomodulators, specifically the immunomodulators such as Imuran and azathioprine or 6-MP, 6-mercaptopurine, which is purinatol in Israel, as well as taking biologics, specifically the anti-TNFs in particular, have to be more cautious about sunbathing. So we usually tell our patient, be cautious. It's not that they have to be walking out in the streets with completely covered up. It's not to that extent. But as I tell my elder daughter, who's 19, I tell her, don't do over sunbathing. It's not healthy for you, even if you don't have IBD.
Yes.
So certainly not for patients taking immunomodulators or anti-TNFs. We say be cautious about it and keep it at a reasonable limit.
But mild exposure is okay because now we have also the information
and put the sunscreens, etc.
Yeah, of course. But we do have now information that most of Israelis are insufficient for vitamin D, and that might be a risk factor for having a greater risk to coronavirus. So still, patients that are taking immunomodulator and biological can have some sun exposure, but not too much.
As everything in life, everything is about moderation. So you have to be moderate about that, and it's not that you have to stay at home entire life. The whole idea when we treat IBD patients, and again, this is what I tell my IBD patients, you have to lead, if we as physicians don't make you lead your life as you wish to, with maybe small compromises, then we failed our task. And the idea is that IBD patient lead his life as regularly as possible within reasonable limits. Reasonable limits are not sunbathing 4 hours, until you're sort of totally reddish, and this is why I mentioned my daughter. Yes. So this is not an idea of regular life in my opinion. But certainly a modest amount of sun exposure is not contraindicated. And as was mentioned, it's very important, as is advised to all the Israeli population and anyone in the hemisphere area that is very sunny, is to have a regular once a year skin dermatologist check. So in particular, if you are taking those medications.
Yes, thank you. So let's talk a little bit about follow-up. One of the questions that repeats itself the most in our community is MRE, the best way to do follow-up, and how is it as opposed to different ways, for example, CT, which has greater radiation, or ultrasound. And I'd also love this question to be answered by both of you. So let's start with you, Professor Shomron.
So I think there are two key points here. One, the main issue is monitoring. So monitoring the disease is exceptionally important. And whatever decisions we make are very much influenced by good monitoring, because we know there is often a disconnect between what the patient feels and what the inflammation or complication that could be in developing within the intestine itself.
Could you maybe elaborate? For example, a patient might feel okay,
so
but
both ways could happen. Patient might feel okay while he have ongoing inflammation and maybe developing complication that one would be sorry later on that we didn't pay attention earlier on and instituted therapy, and also vice versa. So a patient may be on an effective therapy, still having symptoms, some abdominal bloatness, some gassings, some diarrhea occasionally, and we might erroneously assume that the medication is not working and move to another medication unless we really monitor the situation. And sometimes we will find the inflammation is completely controlled and the symptoms are due to another cause whatsoever. And then you don't need to switch medication, you don't need to burn out this medication for nothing. So for both reasons, monitoring is the cornerstone on which to build.
Okay.
And the question was how to monitor. So there are a lot of modalities. I think maybe Lorraine can start reviewing them, and I will follow in then.
Okay, so let's do it this way. So Professor Lorraine.
I would say the first message is that we are using less and less endoscopy, colonoscopy. So this is the first message. We are using less and less colonoscopy, and I even think that one day we will not be using any more colonoscopy for monitoring. I think that colonoscopy will be restricted to dilatation of stricture and screening for dysplasia. CT is irradiating, so I would not recommend it, even if the risk, you have to acknowledge the risk is very, very, very low. But I think, so now the question is that we have 3 tools. We have MRI, we have ultrasound, and we have capsule. So Shomron, even if he will be totally biased, he will talk about a capsule because he's doing a lot and he's an expert in it, so he will tell us everything about the capsule. Regarding MRI and ultrasound, in France, in IBD Center, we do a lot of MRI, so I'm also totally biased. But we do MRI because our radiologists do not want to do ultrasound because it's time consuming. But now we see, since a few years, in France, we have unique access to MRI. But in other countries, the access is maybe less good. In my center, I can have MRI in 1 or 2 days. And we do 20 MRI for Crohn's disease per week. And I think, yeah, it's a lot. But I think that ultrasound is fantastic, to be honest.
Okay, so the only difference, if I can understand you, the main difference is the time that ultrasound consumes as opposed to MRI, but reliability of both is quite well.
No, honestly, if ultrasound is done by somebody who is an expert, it's fantastic. And even now you can look at the colon and not only the small bowel. So it's a kind of point of care test now. You can do it when the patient is coming. So I always say, if you have honestly ultrasound, CRP, calprotectin, and because Shomron is here, TDM, if you have these 4 parameters plus symptoms, I think honestly you can make almost all decisions. So I think with simple non-invasive tools, now you can very in a very accurate way monitor these patients. But I don't know what is the situation in Israel between MRI, ultrasound, and...
Yeah, so Professor Shomron, what's the situation here in Israel? I know for a fact that MRI is a little bit harder to maybe get permission to use. Is that correct?
So I think it's a little bit harder to get, but still we're getting quite a few. I think most patients will get them. There is often a question of how long you will have to wait for. So this is, and sometimes unfortunately some patients will get troubles from their insurers to get MRIs, but in general I think if there is a need, you will get one. So accessibility is an issue. It's not a big issue, but it is an issue, we have to admit. I think there is another layer on this accessibility is also, again, what are you looking for? So we are also doing a lot of intestinal ultrasound even in this hospital in Shiba, so we're very accustomed and we have fantastic service from our doctors in that, and from a GI doctor.
Could you elaborate about the camera, because that's really fantastic technology that we now have?
Yeah, so I think it's also about, we have to understand, and for patients who will be watching this, it's important to understand the 2 aspects of the disease when we look at it from a structural view, and this is, we look at the wall of the intestine, and we call it the transmural inflammation. So how is the wall affected? And we also look at the mucosa, which is the inner lining of the intestine.
Yes.
And sometimes this could be a little bit discrepant from each other. And we as doctors want to get the information on both. And this is why sometimes you will want modalities that address the transmural inflammation, the thickening, the complication, and this is ultrasound or MRE or CT, although we prefer not to use it. And sometimes you really want to see the mucosa, which is a very reliable measure of inflammation, and this is endoscopy or capsule endoscopy. The idea about capsule endoscopy is 2. First, it reaches areas in the small intestine that colonoscopy cannot reach, and second, as I just mentioned, it looks directly at the mucosa and shows you sometimes things that you don't see on MRE or intestinal ultrasound, very sensitive for inflammation. Another benefit for patient, it's a very patient-friendly modality. So patients, we know it from our patients, and I think Lorraine would agree, patients usually love it. There is a small caveat that there is always a risk of retention, so capsule could be stuck if a patient has a stricturing. So this is something we always discuss, and we decide which patient can do it, and there's also now a patency capsule that we can give beforehand. So this is a patency that will dissolve if there is a stricture, so the patient will not be endangered by this retention of a capsule.
Yes.
So sort of screen out who cannot do a capsule. But once you keep this in mind, capsule is a fantastic tool and it's gaining more and more popular. And again, honestly, from our experience with patients just, it's one of those modalities that patients love, because it's really, you
easy.
just see the inflammation, they can see the picture themselves, but without any inconvenience.
Yes, no procedure, actually.
It's a procedure, but very, very
mild.
Convenient, yeah.
Yes.
And very high-techy sort of thing, so it's nice for patients.
Yes, I agree. So Professor Lorен, I have a question about biosimilar treatment. How safe is it? Could you maybe give us a small review?
Wow. Yeah. You know what? I think it will be my shortest review in my career, because honestly, to be very honest and to give you my deep feeling, and I don't know whether Shomron exactly the same feeling, is that I don't think that so much has to be said still about biosimilars. I think now the ones that have been approved and that we use in our centers are quite good. They have to follow a long process. It's not easy to be approved by the European agency or the FDA. It's millions of euros that are invested every time. So when it has the EMA stamp and also your country telling you can use it, honestly, for me, there is no problem initiating or switching to an anti-TNF or to biosimilar for my IBD patients. I have honestly no concern anymore about it, to be very honest.
Interesting, thank you. Professor Shomron, what is your opinion?
Yeah, I agree. I only have a concern about the use of the term biosimilars, because then we are grouping a lot of drugs there that are made on different small technical details that can be very important into one group and say, are they safe or not?
So
I think we have to learn more and more about those agents that are being introduced, because the ones that have been introduced so far, in particular the first one, I think has been shown itself to be very safe, and we have a large body of data to support it. And naturally, by process of medical history, you know, the newer ones that get in, and this is true also for innovative drugs, the newer ones, you have less data.
Yeah.
Even though they are approved. So you're always cautious about new one. This is why I'm concerned about grouping the all biosimilar, where the technical production is so critical.
So another question arises, is there a group of biosimilars that for you feel a little bit uncomfortable to use right away today?
Not yet. I think it's a matter of just gaining enough data. There was a big discussion in the IBD community when the first biosimilar was introduced based on data from rheumatology patients and using a principle called extrapolation. So testing the same drug in rheumatology patients and then saying that by virtue of it being similar effective and safety as an innovative drug in rheumatology, we also assume it will happen in IBD.
Okay.
This principle of extrapolating from another disease was very much debated. So eventually, with the first drug at least, it seemed to work out, and it was proven also in IBD quite safe. We are still not sure whether this will work out anytime with a new biosimilar, because even those minute differences, and there are always minute differences which usually are of no consequence, but time will tell with each new agent whether the specific minute differences make a difference or not.
Yeah. So up to date, both of you feel quite sure about using biosimilars, and if from today new ones will be introduced, we're going to go and check them out specifically and then be able to say if they're safe or unsafe. So there are two treatments that are very far away from one another, but yet our community is very curious about them both. The first one is treatment with small molecules, and the other one with cannabis. So maybe Professor Lorен, you could give us your opinion on both, and then of course Professor Shimon, the details that happen here in Israel.
I think that what we are, and I think it's very nice, is that we had 20 years that was a revolution with biologics, IV or sub-Q, many mechanisms of action, maybe mostly anti-TNF, IL-23 and anti-integrin. So this was the focus the last 2 decades. And now there is a second revolution after this first revolution, which was biologics, which is small molecules, so something that can be administered orally. So having the potential to be a first-line treatment in IBD, I would say that today, to be, I think, to try to summarize, what we know is that the efficacy of these drugs, the good news is that it can have exactly the same efficacy as biologics. So with an oral molecule, it can have the same efficacy as IV or subcutaneous drug. I'm not saying more efficacious, but I'm saying same efficacy as biologics. 2 drug classes are coming mostly, so JAK and S1P. It's a little bit complicated, but these two drug classes will be in the market, and already one is existing. So the difference will be mostly about safety. But what I like with this molecule is that it will be the end of the career of Professor Ben-Orin, because there is no need for TDM. So this is the first point. There is no immunogenicity, so you can stop and retreat. You don't need combo to protect against it. So there are many advantages. I think it will just enrich our armamentarium and so on. It will be more options. But now that we see if the cost is okay, if the reimbursement is okay, I think that my patients, if I am telling them there is an oral drug which is very effective and quite safe, what would you choose? To be honest, at least in Latin countries such as France, people would like it. So I think it's a very interesting revolution.
Do you sometimes have your patients choose? Are there 2 drugs that are almost similar and then you have them choose together with you?
I'm always saying that my patients are choosing, but in fact, in reality, also your patients do not want that you abandon them. And even if I'm telling them you have to choose, they're always telling me, Dr. Perrin, can you please tell me what you think and so on. So it's more a discussion. I don't say, and I've seen that in I'm sorry to say that, but sometimes in the USA where they were saying the risk, this is the risk, this is what you have, this is, what do you do? I'm not doing that. I think it's more discussion. I say you have more options, you have oral, IV, this is the same efficacy. Maybe this one you can take it as monotherapy, maybe, but if it is failing, you can still have access to the other one. So it's an important point. And I would say, very surprisingly, I don't know what thinks Shomron, but very easily at the end of the outpatient visit, you decide I cannot remember spending 1 hour saying, oh, should it be that one or that one? Or I'm lost and so on. I mean, quite easily, with the age, convenience, discussion, you manage to find the good drug for your patient. But I think it's very important indeed that the patient embarks in your management plan, and at least feels that he was part of the decision. But my patient is not deciding alone.
I agree. That's actually lovely. Also here in Israel, I know many doctors do that. And now we're going to take the difficult question like you wanted us to do and present it to Professor Shomron. So Professor Shomron, what is the role of cannabis treatment in IBD? And specifically, I'd like to know, does it help only with pain management or does it also decrease inflammation?
So thank you for referring me this question, not this patient, but this question, Lorraine. Yeah, so cannabis, I think, is a very helpful medication as a support medication. So I use it on patients that we have almost exhausted all options and they are still suffering from pain, from nausea and weight loss. So it's a very good supportive medication if you know how to use it, if you acknowledge the side effects, and there are side effects, if you acknowledge the fact that about 10% or 15% can have addiction to cannabis. So it's a different addiction than heroin or cocaine, so you don't have the physical parameters of addiction, because it's just a matter of how the drug is released from the body, how it's evacuated more slowly. So people don't think about it as addiction, but it is addiction. So we have to put that in the right context.
What are some side effects that you've mentioned before, for example?
We know from some studies, especially in pediatrics, in children, but there is some data already coming from elderly patients that prolonged use of cannabis reduces some cognitive functions. And this is especially concern, I think, for our young patients who sometimes take it for long periods. So
students, for example, people that are still working jobs, not in pension.
Especially them, but I don't see anyone, knowingly sort of willing to waste part of his brain and just do like, I don't care about that part of my brain. If 10 years from now I suffer from some slight, reduction in my memory function, in whatever function. So I doubt if anyone would do that knowingly. And I think it's a lot about suppressing those thoughts or just ignoring it or not knowing the facts. So I think that has to be put on the table. But all our medication have side effects. Any medication we take, even the simplest one, and this is part of the balance. So even if we give other medication, painkillers, they do have side effects, and we put it in a balance. So, but the other notion that cannabis reduces inflammation, I think this is still, even though Israel is one of the birthplaces of cannabis treatment for medical treatment, and still this has not been proven beyond test in the laboratory. And as someone who has an immunology laboratory, I always tell my patient, I can almost show any substance to be working on cells in the lab and reduce inflammation.
But
sometimes I illustrate, I tell them if I take cells and I go to the sea, to the beach, I take a lot of sand and I put it on the cells in the test tube, they will not feel right, they will excrete less material, and I will write a nice scientific paper saying beach sand is very good for reducing inflammation in the lab.
Yeah, but it not might work the same in our body.
Exactly. So the only study actually in the world is an Israeli study led by Dr. Tina Naftali from Meir Hospital, where she took, it's a small study, but it's 20 patients she took and did endoscopies before and after cannabis with a placebo. And this did not show any effect on inflammation, even though patients did feel well, statistically significantly better in terms of their pain, in terms of their appetite. So again, showing that when you test it right, you don't see any effect on inflammation. And as we discussed, it's very important to control the inflammation to prevent future complications, etc., and to really control the disease. So overall, I think this is a right context to look at it. Patients who are in pain, in severe pain, and you don't have good measures to control the disease that causes the pain, I use cannabis. If you have a better way to control the disease itself, and by that also controlling the pain, this is the first, second, and third choice.
Thank you. Professor Lorен, is it the same in Europe? Is cannabis used as the last resort after exhausting other possibilities? Maybe just in a sentence.
Beyond my personal experience, I would say that I think cannabis is very interesting but it's not allowed to use it in France. It's much more complicated to use it even for sick patients. So unfortunately, we don't have the experience with cannabis for our IBD patients. So you see it will be quite short. And so I will need to come to Israel for me, myself, and my patients.
You're all welcome. So Professor Lorrain, our community would like to know to what extent the calprotectin test does reflect on the status of IBD.
I think it's a fantastic tool. Honestly, I'm using it more and more now, so we can do it at home. And I'm very convinced that in the next years, we'll not need any more endoscopy. And that if you use, for instance, a combination of ultrasound or MRI plus calprotectin, you will know everything. You have simple rules to know, is that you need to know what is the calprotectin of this patient, because the calprotectin level can be different from one patient to another one, from one disease location to another one. So if you have one isolated calprotectin, it's very difficult to make a decision. But now if you look at all clinical data, clinical trials, what we know, clearly if you know the evolution of calprotectin over time and you follow the patient, you know his story, I think that now we can make some decision based on calprotectin. And now, even if I would say until a few months and years ago, when I had elevated calpro, I was confirming, doing MRI, checking. Now more and more, I'm doing some decision only based on calprotectin.
Thank you very much. Thank you very much, Professor Lorrain, the European President of the Crohn and Colitis Organization, and thank you so much, Professor Shomron, the Chair of Gastroenterology Department in Shiba Tel HaShomer, and also the Israeli IBD Society. And thank you all for honoring us with your presence today. Stay well.